In this video, we will be discussing medications that are available for the treatment of COVID-19. Treatments for this coronavirus continue to evolve. The one drug that has previously been proven to be efficacious in other coronaviruses and now in SARS-CoV-2 is the ribonucleotide analog Remdesivir. This adenosine analog inserts into the growing RNA chain and causes premature termination, thereby preventing RNA replication. This agent is given intravenously, 200 milligrams on day 1 and then 100 milligrams for an additional 4 or 9 days. There are 5 sponsored phase 3 trials underway. The preliminary findings from the NIH randomized controlled trial were recently shared. Treatment for 10 days was associated with a statistically significant 31% shortening of hospital stay, 11 days versus 15 days for the control, p less than 0.001. And there was a trend toward mortality reduction, 8% versus 11.6%, p equals 0.059. Because of the benefit was demonstrated, continued comparison of Remdesivir versus no treatment was felt to be unethical, and the NIH is now sponsoring a second trial comparing Remdesivir versus Remdesivir plus the JAK1/2 inhibitor rescinded. By blocking the JAK-STAT pathway, this monoclonal antibody prevents the production of the cytokines IL-1 and IL-6. Remdesivir will be given for 10 days and rescinded for 14 days. This trial has made Remdesivir available to many more institutions. However, it should be emphasized that there are limited supplies, and many countries may not be able to acquire this drug. Unfortunately, Remdesivir does not appear to be a home run. In other words, it modifies the disease course, but it isn't curative, only providing modest benefits. A second treatment also shows preliminary evidence for benefit: convalescent plasma. Patients who have documented SARS-CoV-2 infection and who, at approximately 28 days after onset of symptoms, have high IgG antibody titers to the virus are eligible to donate plasma. In an underpowered randomized clinical control trial from China, 52 patients received such convalescent plasma and were compared to 51 who did not. The number of patients who cleared virus from the blood was significantly higher in the treatment group at 24 hours, 45% versus 15%, 48 hours, 68 versus 32%, and at 72 hours, 87 versus 37%. As shown on this graph, in patients with severe disease, the plasma-treated group demonstrated a statistically significant shorter time to clinical improvement, a higher percentage having improved at both 14 and 28 days. There were trends toward reduced mortality and earlier discharge. The trial had to be stopped because there were not enough active cases in China following their aggressive lockdown. Additional trials are ongoing. It should be pointed out that convalescent plasma has been used to treat infections for over 100 years and has been used to treat rabies, hepatitis B, polio, measles, influenza, Ebola virus, SARS-CoV-1, and MERS. Over 7,000 patients have received this convalescent plasma and have experienced only rare side effects. What about chloroquine and hydroxychloroquine? As outlined in my recent video on the IDSA guidelines for the treatment of COVID-19, earlier studies that purported to show benefit were biased, poorly designed, and drew unjustified conclusions. There have now been 2 randomized controlled trials that have revealed no benefit, and 1 observational trial from the VA health system that demonstrated a doubling of mortality in those treated with hydroxychloroquine. Our more recent observational trial showed no harm associated with hydroxychloroquine or chloroquine. As a result of the randomized trials and the observational studies, the FDA has now revoked its emergency use authorization EUA for chloroquine or hydroxychloroquine in the treatment of COVID-19, and these agents are not recommended for treatment or prevention. Anecdotal evidence also suggested that the antiretroviral drug combination Lopinovir-Ritonovir would be of benefit. However, in a controlled trial, this combination proved to be of no benefit. With regards to non-steroidal anti-inflammatory drugs, or NSAIDs, like ibuprofen, the WHO has rescinded its warning, and to date there are no peer-reviewed papers documenting that these agents cause harm in COVID-19. Now let's look at potential treatments for cytokine storm. First, we need to examine how this virus stimulates cytokine release. Let's review how the virus enters human cells and reproduces. Remember, in the first video in the course, we discussed how this coronavirus invades human respiratory lining cells. The virus binds to ACE2 receptors through its surface knobs, and within 10 minutes of binding to the cell surface, the virus is endocytosed and enters the cell cytoplasm. Viral RNA is quickly replicated using a viral-specific replicase. The replicated RNA strands are assembled in the cytoplasm as nuclear capsids. When the virus binds to the outer surface of human cells, it stimulates two toll-like receptors, TLR2 and TLR4. These receptors signal danger to the cell and activate an inflammatory cascade. Replication of the foreign RNA also stimulates additional internal toll-like receptors, TLR7 and TLR8. These receptors activate interferon as well as the inflammatory cascade. Recent studies reported in Cell reveal that this coronavirus contains inhibitors that block the interferon response, an important mechanism for killing the virus. TLR2, 4, 7, and 8 all activate NF-kappa B, resulting in the production and release of multiple cytokines, TNF-alpha, IL-1 beta, and IL-6. All three of these cytokines stimulate a rise in body temperature, resulting in fever. The marked rise in cytokines also stimulates small vessel coagulation or thrombosis, and the infiltration of infected sites with macrophages and neutrophils. High levels of cytokines are likely to explain the development of ARDS, hypotension, as well as liver and renal failure. If we control cytokine production, perhaps we can reduce these severe complications. One well-known way to reduce cytokine-induced inflammatory response is to administer corticosteroids, and preliminary findings from a randomized controlled trial from Oxford University and the National Health Service of Great Britain was recently released on June 16, 2020. In this series, 2,104 patients were treated with 6 milligrams of the corticosteroid dexamethasone once per day for 10 days, while 4,320 received the usual care. Among those requiring supplemental oxygen, mortality was decreased from 25% to 20%, a 20% reduction. And for those requiring mechanical ventilation, dexamethasone reduced the mortality from 41% to 27%, a 35% reduction. It should be pointed out that previous trials of corticosteroid treatment have failed to show benefit, and in SARS-CoV-1, high-dose corticosteroids result in an increase in viral load. However, the results of this randomized dexamethasone treatment are likely to be accurate given the trial design, the large number of cases, and the integrity of the NHS. Based on these preliminary findings, I would strongly consider giving dexamethasone to patients requiring O2 supplementation or ventilatory support. No benefit was seen in patients not requiring oxygen supplementation, and in these patients, this corticosteroid should be avoided. As soon as I have further information, this video will be updated. With regards to the monoclonal antibodies designed to inhibit IL-6 release, Tocilizumab and Sarilumab, the IDSA has assessed the potential benefit to be very low. And Sanofi is backing away from their Sarilumab trial and presently are just studying those with severe illness. It appears that lowering the level of a single cytokine is not of significant benefit. To summarize treatment recommendations, specific treatments that are showing benefit include Remdesivir, which shortens hospital stay, but to date has not been proven to reduce mortality. Convalescent plasma is associated with a more rapid clinical improvement and a trend toward decreased mortality. Dexamethasone is associated with a very significant reduction in mortality in patients requiring oxygen supplementation or mechanical ventilation. All other treatments, including chloroquine and hydroxychloroquine, the antiviral drugs Lopinovir-Ritonovir, as well as anti-IL-6 inhibitors, have not been shown to be of benefit. Thank you.